Hi, everyone. Welcome to the Kinsman today. I hope that I can even begin to stand up to the amazing presentations that we've had so far. I have some doubts. Having said that, at a minimum, this talk is going to be complementary to the excellent one that Dr. Dudzinski gave this morning. Because we are going to be talking about some of those kind of patients that she was talking about, but more in an outpatient setting, right? So what do we do? How do we respond when we have patients who are creating various kind of problems, perceived or real, in an outpatient setting? And how do we make decisions about when it's time to terminate patients from practice? So to put this in, I have a specific context. I have worked in a relatively rural area in my previous job, in a more isolated setting. Now I work at Kaiser Permanente, which of course is an insurance company in addition to being a medical provider, and that has its own set of challenges. And so that's one of the lenses that I bring to this, is that one of the things we're going to argue is that setting matters when you're making these decisions. And we will work through some cases. Apparently, I can see the chat. I am definitely going to be asking you to participate. If you don't, this is going to be a 15-minute talk. So you can either do that in the chat, or we're a pretty small group. So if you want to if you want to just turn on your mic and say something or put up your hand and Dave can call on you, you're more than welcome to do that too. And I welcome interruptions at any point during this. So let's get started. We have some objectives, and as I mentioned, we're going to talk a little bit about why this is important and what sort of our duties are in this setting. We are going to talk about the impact of practice setting, which it's interesting that I called this out. We're going to talk about some other things too, but Dr. Dudzinski actually covered those pretty well. So we'll maybe focus a little bit more on the impact of practice setting on the ethics of termination here. And we're going to describe a process-based approach that I think is a good approach and maybe even a best approach compared to various ones that I've seen in the past. So let's start with the fiduciary relationship. Beecham and Childress describe the patient-physician relationship as a fiduciary one. And what that means is that it's founded on trust, so covenant of trust, and confidence, right? That's a relationship that goes in both directions. And the physician has specific duties towards the patient as a trustee for the patient's medical welfare. So the physician has an obligation of protecting the patient's well-being and the patient's rights, in a sense that to some extent the patient shares, but really not to the same extent. The patient, I would argue, does not have a moral duty to make the physician's life better, whereas physicians do have a moral duty in that direction towards patients. And this is described by the American Medical Association, who described this relationship as a covenant of trust in which physicians commit themselves to responding to the needs and promoting the welfare of patients. And we see that going back to the Hippocratic Oath, right? That physicians put their patients' needs before their own. I do want to comment at this point that this is not necessarily exclusive to physicians, but the physician literature is what has articulated some of these issues most explicitly. There are other people who provide medical care, whether primary or secondary medical care, specifically PAs and nurse practitioners. For nurse practitioners specifically, there is a little bit of literature about this. The American Nurses Association Code of Ethics is totally silent on this issue. And I think that represents not that this is unimportant to nurses, but the Nurse Practitioners Association don't have their own code of ethics. They've been trying to get one for about 20 years, and I'm not totally sure why that hasn't happened yet. But they don't have a code of ethics that is specific to practitioners. So they are governed by the American Nurses Association Code of Ethics. And most nurses do not provide care in the same context in which, for example, physicians provide care. So I also want to recognize that the American Medical Association Code of Ethics goes back to like 1847, I think. And during the vast majority of that time, most physicians were self-employed. So their lens was as a more contractual relationship between physicians and patients during the vast majority of that time. I think it was only in 2016 that a majority of physicians in the United States became employed. During that entire time, the vast majority of nurses have been employed. So their relationship to patients is a little bit different, and I think their code reflects that. But there is an argument from some nurse practitioner ethicists that because of the more relational orientation as opposed to the contractual orientation that the Physician Code of Ethics has, this relational orientation that nurses have with patients as how they define their relationship with patients. Nurse practitioners, some of them argue that that imposes on them a higher standard when it comes to termination of patients. So I want to acknowledge that there is not a lot of literature to call on. I am going to assume that the issues are essentially the same. I am going to assume that in both directions, right? That nurse practitioners and PAs are not required to tolerate more abuse because of the relational orientation that their codes of ethics bring to patients. But I am also going to assume that they have the same duties to patients that physicians do, even though that's not called out in their code of ethics either. So I'm going to treat these as indistinguishable. And I think this could apply also to social workers who are working in individual practices and to other caregivers. And I know that there's a number of people with different backgrounds on this call, so I would really welcome, especially I see a whole bunch of people who I know to be social workers. So I would really appreciate any perspective you want to offer on how these issues differ for different practitioners. So going back to the American Medical Association Code of Ethics, you would think that this covenant of trust, having established that this is required, the American Medical Association would have something substantive to say about terminating patient-physician relationships. And they do have a whole opinion about it. And basically it says you need to give them enough notice, right? This is not in my view, this is not an ethical opinion. This is a procedural opinion. This is saying what, and I guess there is some ethics in this. I'm not going to say that giving a patient enough notice to find another provider isn't important ethically. But this is more about the process of terminating a patient than about justifying that from an ethical perspective. And I think that's a miss, frankly, on the part of this code. I will acknowledge that there is another opinion in the Code of Ethics that enumerates a list of patient responsibilities, and I think you could probably use that as a starting point for reasons that it might be justifiable for a physician to terminate a patient. But it's interesting to me that the opinion officially makes a statement about how to do this, but not whether or when to do this. So that's what we're going to talk about. Any comments or anybody want to disagree with me so far? Okay, I'm going to follow Dr. Dudzinski's lead and approach this through the lens of several cases. And we are going to vote probably just in the chat, I think. So Marina Carter is a nurse practitioner who is seeing a new patient. She's never met this man before. His name is Jason. He's 44 years old. She is a little bit late to the appointment, 7 minutes late, and he's pretty irritated by that and expresses his irritation verbally, although not in a way that would be problematic, I think, for most people. But when she starts to ask him about his medical and social history, things that are part of his normal medical intake process, he's also getting pretty irritated by that. I don't have time for all this. And they go through the visit. It's a new patient visit. He doesn't have any specific complaints. But at the very sort of on the way out the door, is there anything else? He brings up his low back pain. And he says he takes 30 milligrams of OxyContin and he needs a 3-month supply for that. And Ms. Carter demurs a little bit and says, I need to get some records from your previous PCP before I feel comfortable prescribing 3 months worth of quite a high dose of OxyContin. But I could prescribe you a week's supply to make sure that you're adequately treated while I'm in the process of getting those records. And at that point, he jumps up, shouts, "Stop wasting my time, you stupid bitch," and slams the door on the way out. So the question is, would Ms. Carter be justified in terminating the patient-provider relationship at this point? And yeah, so one of you is saying that you propose that the therapeutic relationship hasn't really been established, and I think that's correct, right? So there's a lower standard here, right? You've not actually provided any medical care to this patient. I can only see the chat, so can I assign somebody, maybe Dave, to sort of tell me which way this is trending, because I can see your comments one at a time. They pop up as a notification, but I can't actually see the whole chat for reasons that are not totally clear to me. So are we leaning yes or no on this? It warrants a conversation and perhaps a behavioral contract. I think that's an excellent. Mickey Varner says no. So are we saying that, maybe one of you who's saying no, are you saying no, you're not justified in terminating because we should work harder to establish relationship with this patient? Or no, you're not justified in terminating because we actually haven't started yet?
For me, it's both.
Okay. Hi, Melanie.
Hi.
I'm getting a sense that there is a need for some more conversation here. Let me ask another question. If we choose, so I think some of our, maybe notably physicians, are saying that you actually haven't established a patient-physician relationship, so it's not there to, or a patient-provider relationship. This is a nurse practitioner. So there isn't a relationship to terminate. But assuming that Ms. Carter wants to go ahead and continue to care for this patient, let's talk about what are the behaviors that we've identified that are inappropriate here. What are, if we're going to talk about setting some boundaries, what are the behaviors that, and I know I didn't list them for you, so now I'm asking you to remember. What are the behaviors that are problematic? Name calling, called her a bitch. Anything else? Yelling, raising voices. The degree of anger. Yeah, irritable right from the beginning of the visit and kind of escalating as things went on. Even to pretty benign interventions like asking about a social and medical history, right? He also slammed the door on the way out. I would consider that threatening, right? So in this case, all of the behaviors that we're talking about, all of the things that we're concerned about are patient behaviors, right? And I sort of put them on a continuum here. Actually, I meant to ask you for behavior-related reasons that you've seen patients fired. I forgot. But here are some that I've seen patients fired for, including, I would say at the milder end, sort of not taking medications as prescribed, not sort of being compliant with the plan. And I don't love the term compliant, but I use it here because I think people who, I prefer the term adherent, but I think when physicians want to fire patients, they are framing it as compliance. They're not doing what I say, right? We could argue about where all of these things should go on this spectrum, but I think we would all agree that in this, and in fact, Dr. Dudzinski talked about this too, there's abusive behaviors at one end of the spectrum over here on the right, verbal abuse to physical assault, and the approach to those is probably a little bit different. And then there's behaviors that are potentially, it's hard to hear with the competing sounds. Are the competing sounds coming from me? Or are there people who are not muted? So maybe check and make sure that you're muted if that's happening. It's also, okay, you don't hear any commuting sounds. Okay. So there is this spectrum of behaviors. And I just want to start with this, that our response depends on where on the spectrum of behaviors this falls. I think also we need to think about sort of the chronicity of these behaviors. A single physical assault might be ethical justification for terminating a patient, whereas, obviously missing one dose of a medication that a patient takes regularly would not be. And even, I would argue, chronic medication non-adherence, we have pretty high bar before we terminate patients for that. We'll get more into that. Are there any other factors or any other sort of causes that you think we should consider at this point? That's a good question. Was the expectation of narcotic prescribing discussed at the time of scheduling? I don't know the answer to that question. This is a real case, and all of these are real cases. And I don't know the answer to that question, but it is a question, right? I do, and to be honest, if I have to guess, I would say no, but I don't know the answer. Any other considerations that we want to think about? Okay, let's talk about another case. And again, I am retreading a little bit some ground that Dr. Dedzitsky covered. Annabelle is 64 years old. There's a significant disconnect between patient and I only can read the beginning of that. Can somebody read that comment to me? Because I can read there's a significant disconnect between the clinic's expectations and the patient's expectations. And then that's all I can read.
Hi, Laurie. This is Christine Maloney. I'll read it since it's my comment. I was
Thank
typing
you.
it as you were saying. Any last thoughts?
Yeah.
But basically, this sounds like somebody who he has different expectations than what the clinic expects. And so I think if before any decisions are made about moving forward, I think it's helpful to have him articulate what his expectations are and then really lean into, where's the difference here? Because he may understand then what the clinic expectations are and be like, I don't want to be here.
Absolutely. I think that's a great point. And I also want to say the clinic actually should, again, we're going back to the excellent presentation from this morning. I think the clinic should probably have a policy about this, right? So that they not only can say, so that they can say very concretely, this is how we handle requests for narcotics. My old clinic, when I was still practicing clinically, for example, we had an approach to how much we were willing to prescribe at one time and how long that would take, how much time you had to give us in order to process your refills if it was something that needed a specific, that couldn't be refilled, that had to be refilled on an individual basis. And that was something that we could share with patients. So the expectations from our side were very, very clear. But I really appreciate the lens that we also need to give patients an opportunity to express what their expectations are so that everybody's on the same page, right? I have to say, I thought that this particular scenario might be kind of an automatic, like people would be like, oh no, fire that patient. He's brand new. He's already kind of acting like a jerk. And I really appreciate the effort that you all are putting into keeping him in the practice, to at least being open to keeping him in the practice. I will telegraph, obviously, my conclusion here is not going to be just fire whoever you want, right? So for the second patient, Annabelle is 64. She is seeing Dr. Lee, who is somebody she has been seeing for decades. And she has a lot of chronic medical conditions, so he knows her quite well. He has known her for years, and she has generally been a good patient in all the ways that we usually define a good patient, right? She shows up to her appointments, she takes her medications, she is respectful when she's in the clinic, until about 3 years ago. And about 3 years ago, her family began to notice personality changes, and she was diagnosed with frontotemporal dementia. And unfortunately, that's progressed quite rapidly, and she is no longer as respectful as she used to be. Her daughter has brought her in today because she has a cough that's been getting worse over the last several days. And she's also noticing, she lives with her daughter, and the daughter has noticed that she's increasingly agitated over the last few days as well. And Dr. Lee can appreciate the agitation as soon as he walks in the room. She interrupts him, interrupts the daughter, saying, I want to leave, I want to leave. At one point, she accuses her daughter of kidnapping her. So she's getting sort of increasingly upset. She is there for chest complaints. She's coughing during the visit. And when Dr. Lee approaches Annabelle to listen to her chest, she shouts a racial epithet at him and tries to slap him away. So is Dr. Lee justified in this case for to terminate the doctor-patient relationship with Annabelle? No. Nope. Anybody else? Christine, do you want to comment?
I see a lot of no's, but I'm struck that if we changed the dynamics a little bit, people might feel differently. Like, let's say this was a 250-pound man and the clinician is a 100-pound woman and was scared out of her mind, like cornered in the office, really terrified. I understand this patient doesn't, we're framing this is somebody who doesn't really have control over what's happening, but I still think the clinician voice really matters here in terms of whether this person feels safe interacting with them again.
I think that's a great point, because everybody involved in this situation needs to feel safe. Yes. So I agree with what Dr. House is saying. Monica, I am definitely interested in your comments, and maybe could you preface them by explaining what you do for a living?
So I'm a neurologist, and I think the difference for me, and obviously if I feel unsafe because of a patient's disease state, we can put things in place, like I'll stand closer to the door, I'll bring my nurse in with me, I'll keep the door open. But to me, there's a huge difference between someone with capacity and acting this way, whether or not there's underlying psychological issues that cause people to act out or demand, narcotics. I think that's a different discussion. But in my mind, this person does not have capacity. This may not be them. This is not their, they're not making these choices. Their neurochemistry is. So, with safety measures in place, I encourage people to get a psychiatrist opinion immediately and start some antipsychotics, because we assume if we treat that disease, these behaviors will resolve, whereas someone who's maybe borderline or has capacity, I don't know that there's behaviors or narcotic seeking will necessarily ever resolve.
Yeah, I think that's an excellent perspective, and I appreciate that, particularly coming from you. Allison.
Hello. I'm a nurse. And I would just say that I think in this scenario, there could be many, many things. She could have, some worsening of dementia, which as a male, that could have been triggering for her. Is there perhaps having a family member present, having a chaperone present, maybe referral to geriatrics, escalation in disease. I mean, I think there could be a lot of reasons for that, including if we flip the scenario, we had a man with dementia and a female provider, I would still say same thing. I would still say that we need to look at that disease burden and an escalation of that, and is the person gets lost with the dementia, so it's the more the disease than the person that may be acting out at that point, and looking at alternatives to help them feel safe and the provider feel safe during the visit.
Yeah, I agree with all of that. And I do think one of the physicians on this call pointed out that she has pneumonia, or she has something going on from a respiratory perspective, and that absolutely could be worsening all of this. So again, where we place these things exactly on the spectrum is not important, but I do think we are recognizing that there is a difference. Patient one Yes, exactly. What is the provider's justification? And this is going to be the theme that we go through as we consider all of these cases, right? Patient number one, presumably is capacitated. He, didn't give us any indication that he's not capacitated. That's obviously a whole nother talk, but we're assuming he's capacitated unless we have clear evidence to the contrary. He made a deliberate choice, and we don't know if he's apologetic or not because he left, right? I would say there is also a capacitated patient situation where we are very tolerant of that. We had a patient, a very sick patient's been in our hospital for 6 months, and I know her husband quite well. And there was a kerfuffle a few weeks ago because he kind of yelled at the nursing staff. And actually, the kerfuffle came from him. He called me to apologize and say, what do I need to do to make this correct? Because I got some really bad news. I got it in a way that was really, frankly, not ideal. I mean, I will say objectively, it was not ideal. So he was highly stressed, and immediately he was seeking to make amends. Nobody is considering, trespassing that patient's husband from the hospital or anything, because again, he's capacitated, but he's also apologetic, recognizes that he did wrong. A patient like Annabelle, I think, is all the way at the other end of this spectrum, right? Really not in control of her behaviors. And so our obligation here is to figure out what we need to do to make this. Yes. I'm going to come back to that, Dr. Coleman. I see that there are good comments that I'm getting to read half of. I think it's on us to create the conditions for safety, right? To the best of our ability. I mean, it may be impossible to do that in a clinic. This may be somebody who needs to be seen in a different setting, but I do think we have obligations to try and maximize that. And we're going to come back to that later. So, Dr. Coleman, I do want to acknowledge what you're saying about, the experience. Let's assume that the experience of hearing racial epithets is terrible in any context, right? And I agree, people have different experiences with that, right? My guess is in a case like this, where this is somebody he has known for decades and who has always treated him respectfully before, that probably lands pretty differently than somebody that he's never met before. But I do think in the context of racial biases, LGBTQ biases, I think this conversation does get more complex, and that's something, again, we'll come back to a little bit. I know I missed some comments. Does anybody, and I know Christine, you made one that I could only read a part of. Does anybody want to comment on this before we move to another one? Okay, this one, I thought, well, this one was a slam dunk, and I thought it would be. This one, I'm curious to see what you think. So, Emily is a woman in her mid-30s who had a minor surgical procedure on her vulva. It was a benign problem that she found bothersome. It wasn't something that had to be done, but it was very medically reasonable to do because she was bothered by this condition. But she's immediately was unhappy with the result. Within about a week, she was complaining about the cosmetic appearance of her vulva even before her stitches had come out. And she was reassured by her gynecologist that, that things would look different as the healing evolved, and that it was normal with stitches still in, that things would be swollen. But she was very, very upset and increasingly angry. And as she, over the next couple of weeks, she was referred to 2 other gynecologists for a second opinion, and both of them gave the opinion that the healing was progressing normally and that the appearance of the patient's vulva also was normal. I will comment that the patient didn't have any complaints of pain or function. Her concerns were largely cosmetic. So This is not, she wasn't, this isn't that we're dismissing physical pain or something like that. As she's getting these additional opinions, she's getting angrier and angrier, and specifically she's feeling gaslit, and those were her words. But she is sending now increasingly threatening messages through the patient portal. She says things like, "I hope someone mutilates you like you did to me." So this is a message that she sent to her doctor. There was a behavioral contract at some point. She was told that her access to the patient portal would be revoked if she continued to send threatening messages in the patient portal. She did not really stop sending threatening messages. She continued to send threatening messages, but before her access was revoked, the situation came to a head. Her doctor, Dr. Smith, left for work one day and found her car and her yard papered with leaflets warning her neighborhood about this butcher, was the word that she used. There were photographs, so although nobody saw Emily do this, it was fairly clear from the context and from the photographs of her vulva, who had leafleted the doctor's own house. Dr. Smith actually went to work, I think not knowing what else to do, deeply shaken. And when she arrived at work, security was collecting dozens of leaflets from around the building, from the property, and from the elevators. So, would we be justified? Would Dr. Smith be justified in terminating the provider-patient relationship? Should be dismissed, and provider should do a police report. That did happen. Yes, provider would be justified. Does anybody disagree that this would be an indication for termination? I'll come back to that Bay Area Hospital Ethics Committee. There's a part 2 for this case. Nobody's in disagreement with this. The stitches are out at this point, so you could terminate care. And in fact, from the point of view of this specific episode of care, you probably would terminate care, right? Like, she does have needs for just general ongoing gynecologic care. But if this was an equivalent procedure done by the general surgeon, for example, general surgery would no longer be continuing to follow her. Yes. So Dr. Dudzinski is saying that the behavior subverts the therapeutic relationship. And I think that's exactly right. There is 0% chance of restoring trust within this therapeutic relationship, right? Nor, from the other perspective, is there any possibility of restoring safety, right? She went to her house. Like, she's never going to feel safe again. So I will say a police report was filed. But the twist to this case is that this, again, is a real case. It's a recent case, and I work at Kaiser. And this patient has Kaiser insurance, and this physician is contracted as a Kaiser employee to provide care to Kaiser patients. So does that make a difference? And if so, how? Nobody wants to bite on that one.
Yeah, so I also work for Kaiser. So we've had patients recently giving our doctors death threats through the patient portal. I'm going to kill you. I'm going to come to your house. I'm going to find you.
Yeah.
We had a patient who was also an employee badge in on a day off and act threatening to a provider. And we were told that because we are Kaiser and because we are our own health insurance, these patients need to be transferred to other doctors in our group. So I have inherited someone who gave a death threat to one of my colleagues. Whether I like it or not, or I'm comfortable with it or not, that's what we've been told. by legal because we are a unique closed health insurance. So that doctor doesn't continue to see the patient, but I do, or one of my colleagues.
So thank you for that, Monica. I was actually approached by legal because, and I will, not getting into the complexities of Kaiser, but we do have specific obligations to patients as their insurance company that are a little bit different from the obligations that individual providers have as their doctors, right? And in fact, within Kaiser, these are two different companies. The medical group and the insurance are different organizations, which increases the complexity of this. I will say, just because this is such a complex case, that that legal approached me to help articulate. They approached me with the specific contractual language that was involved in the relationship that the patient had through her insurer, to articulate an ethical justification for terminating this patient from the entire OBGYN group, not just from not from Kaiser altogether, and not just from this provider, but the recommendation was that we terminate her from getting OBGYN services, and that we, as her insurance company, this was where there was some justification to go to sort of the other wing of the organization. Basically, what we said was that we cannot reasonably expect anybody who works in OBGYN to take care of this patient. And what we should do as an insurance company is authorize that she receive her care outside of Kaiser for this specific problem. So that's the resolution to that. But there's complexity, right? And similarly, practice setting. If you're in Portland and you're a primary care doctor and you want to terminate a patient, you can do that with a lot of confidence that the patient has other options for care. I was a vascular surgeon in a community of 30,000 people, where, with a bigger catchment area and everything, but me and my partner were the only vascular surgeons in town, and we had a lot more caution, because recognizing in a small community, in a pretty economically depressed area, where a lot of our patients did not have the ability to drive elsewhere. And my moral obligation to prevent people from having strokes and dying of abdominal aortic aneurysms led me to put up with behavior that I would argue not everybody is actually morally required to put up with, including what the primary care doctors in our community, where there were other options, should have to deal with. One of the cases, there's a paper out there about a pediatric patient who has a rheumatologic condition, and his parents are threatening. And for this child, who is not the problem, to get care for his problem, he would have had to go to another provider 400 miles away. There's only apparently like 250 pediatric rheumatologists in the country. So that is something that we need to consider as well. We're doing such a great job of discussing this that I'm going a little bit over time. So I want us to ask, are there significant considerations that should go into these decisions that you think that I've missed? Okay, I think there are. Financial considerations. I think we always have to ask, are we penalizing poverty? Does it pay, and this happens especially with things more at the non-violent end of the spectrum, but does a patient repeatedly no-show because they lack transportation and they're dependent for others on rides? That's actually maybe a problem that we could help with, right? But I would say it would be unjust to terminate somebody just for that, who has that lack of, especially in a community like this, like the one that I am physically standing in, not Portland, in which, it does not have the robust public transportation options that Portland has. Or a patient is dismissed for non-compliance, social determinants of health. Melanie, exactly. A patient is determined for noncompliance with medications that they cannot afford, right? We can't be penalizing people for making a choice between food. And yes, exactly. I appreciate all the comments that you're making in the chat. We really should not be penalizing people for being poor. Especially in healthcare, we should not be penalizing people for being poor. There are cultural inputs here. I was a vascular surgeon. I spent a lot of time talking to people about quitting smoking. And I will never forget a patient who said, in my culture, this is what men do when they get together. And men who don't participate in our group activity, of sharing tobacco, are not really asked back, right? Like I'm not disagreeing with you and I would like to do it, but this is culturally a super important behavior to me. It's hard for me to argue with that. And I think that there are lots of examples of that. Non-compliance, again, we are telling somebody that they need to follow a diet, but we are not making sure that that diet is culturally appropriate for them or offering them any help of how to modify their culturally important foods to be able to be compliant with the diet. I'm going to come back to ability, but we do this all the time in medicine, right? Eat more and move less, but we don't give any guidance about how to actually do that. We give very superficial instructions and expect people to figure out how to do it on their own. And again, if we're firing people for that, we are penalizing them for ability. And I also think we always need to be trauma informed when we are considering this lens. I put this as a case at the end, but I don't think we have time for it. So I'll give an example that actually came from a colleague at OHSU, but who was a social worker who worked with the bone marrow transplant program. And bone marrow transplant patients spend a long time in the hospital, extremely dependent. And this was a pre-transplant visit. And the patient brought up a concern. To his credit, this patient was a Gulf War veteran, had experienced some pretty terrible things and had quite severe PTSD, and his PTSD symptoms were triggered by people who were visibly Muslim. And he was really worried. And again, going back to this is a capacitated, maybe some not fully capacitated in his responses, but he's trying to be proactive because he is apologetic. He doesn't want to be mean to Muslim people, but he is really worried that in a state of debility that he is going to behave in a way that he's not proud of and he wants to troubleshoot. I think that's an appropriate conversation to have, and just saying don't be traumatized when you see somebody in a headscarf is not helpful in this situation, but firing a patient who is so vulnerable in that setting would also be something I would have some trouble with. So any other comments about this? Anything that we missed? Okay, so again, echoing Dr. Dudzinski, we have an opportunity here to do some organizational ethics. And we've been talking about individual cases, but we can create more just organizational processes, in this case, policies, processes, that help to support procedural justice in how we are dealing with these patients. In my experience, the usual thing is that either there's no process, either the doctor just says, I don't want this patient on my panel, and something happens. Or there is a committee that consists of the clinician, maybe the clinic manager, maybe the clinic social worker. And in my experience, that committee functions as a rubber stamp. I actually think that's worse than not having a committee. I'll stop using the air quotes, you know what I'm trying to say. I think that's worse because it gives this gloss of procedural justice. It gives the impression that we're being deliberative about this, but in fact we are not. I was invited to one of these committees when there was a specific question that was related, but was a much sort of higher level question than what they typically were dealing with. And they invited me, and I was like, yeah, this whole, no, I need to come to all of these meetings, right? Like not just when you, I can't even remember what the ethics question was. They did not love it because they were never pushing back. They were literally terminating 100% of the patients who presented. There are problems. There are all kinds of problems. I don't think it's fair to patients. That's the biggest problem, but it's actually pretty unfair to other clinicians. In my experience, what often happens here is that you have eight primary care providers in a clinic. 3 of them want to fire everybody, and 2 of them will take literally anybody on their panel. So guess what happens? Those 3 doctors fire everybody who creates even the tiniest problem, and all of those patients end up on the panel of the other 2 doctors. This has significant impacts on the quality of life for those providers. I shouldn't say doctors, they could be anybody. You know, the doctors who have fired all of the problematic patients show up, they stay on time, they've got 15 minutes for each patient. I mean, this actually impacts their incomes, right? Because the doctors have accepted all the problematic patients who are often sicker, often mentally ill, often have, you know, movement disorders, all kinds of problems. It takes them 45 minutes to see these much more complex patients, and it introduces real injustices actually within the medical group, in addition to the obvious injustices that, you know, that are happening to patients. Anybody want to comment on that? Has anybody seen this play out? Okay. So I want to propose something else that I think is a better practice. And I didn't invent this. Actually, some of you know Chris Keogh, who was an ethicist in Longview, who preceded me there, and she really developed this process that I think is a best practice and has worked incredibly well in, admittedly, this relatively small community. There's a committee, again, but it's a real committee, and the goal of the committee is to resolve problems rather than just to make decisions about termination. So explicitly, the goals of the committee are to identify the problems that are causing a breakdown in the relationship between the provider and the patient, and to try to solve them. And there's also a standard process. So there's actually a form that if you want to terminate one of your patients, typically the terminations are from that specific provider, not from the clinic as a whole, although there were certainly occasionally cases where we terminated the patient from either the clinic or the whole organization. But generally, it was a provider-to-provider transfer that was being requested. But you had to do some work. You couldn't just be like, the clinician had to attend. So again, we're creating a little bit of friction here, right? It's not as easy as just being like, I don't want to deal with this. Clinic manager attends, the ethicist attends every meeting. Social worker, care coordinator, nursing leaders, often the social work leader. There's typically a group of 8 or 10 people, sometimes more at this meeting, and we would invite other people ad hoc. And again, the case was discussed, cases presented by the clinician typically, along with the reasons that they want to terminate the patient. And then everybody asked questions. And this is a form of procedural justice, again, because there is a real robust process, and the expectation is that everybody is pushing back, right? That termination is not the expected outcome, but it is only if we exhaust all the other options. I want to share, I think we have time to share one case. A 52-year-old diabetic patient, he agrees to insulin whenever he's in the clinic. He takes all of his pills. He is generally a compliant patient, but he really needs insulin. His blood pressure, his blood sugar is very poorly controlled. And whenever he's in clinic, he says, yeah, okay. And he doesn't take it at home. And his blood sugar is getting worse and worse and worse, and his PCP is getting really frustrated with him. So is there anybody who should be at the meeting? And what questions should we be asking? Anybody who's not on that previous list? Nobody's biting. Okay. We invited the diabetes educator, the spouse. Excellent idea, Allison. This particular patient did not have one, which is potentially part of the problem. But yes, absolutely. Anybody who can be supportive with the patient, right? Anybody who lives with the patient. So if there had been a roommate or something like that, I agree, that would have been great. There wasn't in this particular case. Clinical pharmacist, yeah, great idea. And I don't remember if we did or not. So what questions would you be asking? Yeah, Sarah, vision issues, exactly. Call the patient's pharmacy. Is he filling the medication? Yes. What the copay is? Can he afford it? Have we asked him if that's a problem? Ask him about finances. Melanie and I mind melding, which has definitely happened before. All of these are good questions. And we asked all of them. Needle phobia, 100%, right? Is the barrier that he wants to, but he just can't do it. The nurse case manager was there. And I think if I recall correctly, it was the nurse case manager who asked, yes, Monica, I think that's a good point too. And that's a whole other talk, right? But why do we demand that people be compliant? Does he know people who've used insulin? What happened to them? These are all fantastic questions, right? The point is, what is the barrier? This guy is telling us that he wants to take insulin, that he wants to be healthy. In every other aspect of his medical care, he is on board with the plan and he goes home and he does what we tell him is the best thing for his health. What is the problem with this? Does anybody want to take a guess? Some of you got close. I'll give you a hint. It's something that is actually probably a problem much more often. Oh, actually, I bet Dr. Coleman can guess this because I've heard him talk about this. Probably more often a problem than we think about. Scared of low blood sugars, that does happen, but that wasn't it. A stigmatized issue that is much more common than we think it is. He was enumerate. We were handing him, I don't remember if they were dial-up pens or if he was actually having to draw his insulin up, but we were demonstrating for him how to do this in the clinic, assuming that he could read the numbers on the bottle. And when we handed him the pen, and I would say more often than not, people are illiterate. This patient actually could kind of read, but he just had no idea when it came to numbers. And so when they were teaching him, we were drawing it up and saying, okay, show me how you would inject it. And he was doing that okay, but nobody had ever bothered to figure out if he could actually draw the medication up himself. And I do not recall whose job it became to teach him numbers, but it's actually relatively easy compared to teaching somebody to read. You know, he only needed to be able to look at the, you know, like they made a chart with big numbers and they kind of taught him to shape match essentially. And this totally solved the problem. I think at the other clinic that I mentioned, which was in the same organization, I think that patient would have been fired. And I think he would have hopefully found another clinic where they were more receptive to his needs. But I think this is the best practice, right? We solved this problem for the patient and potentially other future. There you go. Dr. Coleman, who's an expert on this, is saying low numeracy is more common than low literacy. And low literacy is also pretty common. I want to, we'll skip this. I want to end with a quote that I really like that summarizes this. I did not put this in the references for this talk because I'm not recommending this, but I have seen this in researching this subject. I have seen this paper cited, I don't know how many times, like in the last 5 years. It's from 1978 and it's called Taking Care of the Hateful Patient. To his credit, Dr. Groves, I think, is a psychoanalyst. So transference and countertransference is kind of his thing. But I need to read my slide. Dependent clingers, this is a taxonomy of problematic patients. dependent clingers, entitled demanders, manipulative help rejectors, and self-destructive deniers. And they evoke aversion, a wish to counterattack, depression, and feelings of malice. I hope we all agree that this is appalling, right? So two physicians, actually a medical student and his dad, who was a physician, wrote a paper called 40 Years Since Taking Care of the Hateful Patient. And I really like this as a way of framing what we are talking about. Treating any patient as hateful warns us that we are perceiving neither the patient nor our calling in the proper light. And I think that's true whether we're physicians or nurses or social workers or PhD ethicists. And so I just want to close with, boy, I'm right on time. I wanted more time for questions. We want to think about procedural justice, but I also want to say there's an element of virtue ethics in here, right? What kind of providers do we want to be? What kind of ethicists do we want to be? And are we upholding those virtues when we care for these most difficult of patients? So we have 1 minute. I'm actually happy to stay a little bit late into lunch if people have questions, but thank you so much for your participation and for coming. I appreciate it.